Bismillahirrahmanirrahim. In this video, we will discuss the physiology of thyroid hormones. Now, thyroid hormones are very important for your board exams because you're going to have MCQs regarding hyperthyroidism, hypothyroidism, and you can only answer them well if you know the physiology as well as the pathology. So, for now, we are concerned with the physiology of thyroid hormones. Now, thyroid gland, although the C cells, the parafollicular C cells of thyroid gland produces calcitonin, but we will discuss that calcitonin afterwards. Now we are concerned about the thyroid hormones, which are the triiodothyronine and thyroxine. Triiodothyronine is also called as T3 and T4. Now, these are iodine containing hormones. So, if there is a region in which there is iodine deficiency, so there are chances of hypothyroidism, and so iodine deficiency is a very important cause of hypothyroidism. Now, the production of thyroid hormone is very important and very interesting. So let's have a look on this diagram and understand how are thyroid hormones produced. Now, there are several steps. Let us have a look on the steps. First step is that there is absorption of iodine. So you can see the absorption of iodine with the help of a transporter, which is basically a co-transporter. It transports iodine along with sodium. So this is a transporter, and this transporter can be inhibited, competitively inhibited by other ions such as percolate and pertechnetate. So we these are the inhibitors for iodine absorption, and so they are also the inhibitors for production of thyroid hormones. Once iodine is absorbed, it is converted into I2. Now, this step may be, supported by an enzyme called as thyroid peroxidase. Here you can see thyroid peroxidase. Now, thyroid peroxidase is one of the very important enzymes involved in the formation of thyroid hormones. It basically regulates three steps. We're going to study these three steps categorically when we have a look on the theory. For now, just understand that iodine is being absorbed and it is converted into I2. Now, there is an important protein called as the thyroglobulin, which is represented by this capsule kind of a diagram and labeled as TG. This is thyroglobulin. Now, thyroglobulin basically provides a scaffold, or it provides a platform on which thyroid hormones can be produced. Thyroglobulin have several tyrosine molecules, or you can see the tyrosine molecules represented by these circles over here. Now, what happens is that this iodine is added on these tyrosine molecules, and this process is called as organification coupling. The addition of iodine on tyrosine molecules of thyroglobulin is called as organification coupling, and the enzyme involved is thyroperoxidase, and this is all happening in the follicular lumen. Now, what is the follicular lumen? If you have a look on histology of thyroid gland, the thyroid gland basically has, colloid filled follicles, and the production, let me just draw it for you right over. You can see, for example, these are the colloid filled follicles. Now, there is some place between the follicles, and this is the area where there are parafollicular cells where calcitonin is produced. But the major productions, which is this all, which is the production of thyroid gland, so follicles are involved in the production of this thyroid gland. So you can see that follicular lumen is the place where this organification coupling is taking place. All right, now once we have a concept of organification coupling, what basically happens is I2 iodine is added to the tyrosine molecules of thyroglobulin, and those tyrosine molecules are converted into monoiodotyrosine called as MIT and diiodotyrosine called as DIT. Right? So there are MITs and DITs on this thyroglobulin molecule. Now, what basically happens is if an MIT, MIT means which has one uh, iodine. Now, let me draw this for you. If one MIT is added or is combined with another MIT, so that will make something with two iodine molecules. But this kind of combination usually does not exist, right? Usually what happens is that there is a DIT also involved, which is diiodotyrosine. So what happens is that a diiodotyrosine is added with a monoiodotyrosine and this forms T3. And if a diiodotyrosine is added with a diiodotyrosine, this forms T4. So we have the formation of two hormones, the T4 and T3, and these hormones are formed by the combination of tyrosine, you can say organophide tyrosine molecules. So this is basically the formation of thyroid hormones, the T3 and T4 hormones. Then, let's further have a look on this diagram. So they say that T3 and T4 are produced and they are released into the circulation. So we take iodine from the circulation and ultimately iodine containing thyroid hormones are released into the circulation. What basically happens is our thyroid gland majorly produces T4. So the main secretion of thyroid gland is thyroxine, which is T4. But among these two, the T4 and T3, T3 is a more potent hormone. It has more functional significance. So what happens is that, as you can see, T4 is released in a quantity which is much higher than T3. So in the periphery, in the effector organs, this T4 is converted into T3 since T3 has greater significance in functionality. So you can see the T4 is converted into T3 and this happens in the peripheries. The enzyme used for this is 5D iodinase. Now this is very important. We will revise these things in pharmacology. We will study certain things, certain hormones or certain drugs which will inhibit 5D iodinase. And of course, inhibition will mean less amount of T3. And less amount of T3 means less effects produced by the thyroid hormones. All right. So T4 is converted into T3 with the help of 5D iodinase. But another point is that there is a byproduct produced by T4 which is called as reverse T3. So basically T4 is producing T3 which is one of the most potent thyroid hormones and reverse T3. Now reverse T3 has some other significances, we will study them later. For instance, let me tell you significance. If you get a scenario in which there is thyroid hormone deficiency in a patient and the doctors prescribes injecting exogenous T3. So if a patient is getting exogenous T3, now the T3 level in the body will be raised, but reverse T3 will still be low because reverse T3 is produced by T4 and it will not be present in exogenous injected T3. So you know you do have importance and you realize those importance when you get a scenario. For now, just understand that T4 is converted into T3 and reverse T3. All right, now I think we can have a look on the theory. We have discussed it quite thoroughly. So what are they saying in the theory is follicles, right? So the thyroid hormone is mainly produced inside the follicles, and they say the deiodinase converts T4, which is the major production, into T3, which is the major potent hormone, and peripheral conversion is inhibited by glucocorticoids, beta blockers, and propylthyroid acid. This conversion of T4 into T3, this conversion is inhibited by glucocorticoids, beta blockers, and propylthyroid acid. We will study this propylthyroid acid and methimazole when we study the pharmacology. So don't you worry about that. Just have a first introduction of this glucocorticoids, beta blockers, PTU, right? Then they are telling you about reverse T3, which is metabolically inactive byproduct, but it is a byproduct of conversion of T4 and yes, that reverse T3 is increased by growth hormones and glucocorticoids. You see, glucocorticoids inhibit the conversion of T4 into T3, but as a result, the formation of reverse T3 is increased. So there is a very interesting combination. Now, glucocorticoid is something which you get very commonly in clinical scenario because it is what you call as steroids. You say na that somebody is going to gym and he has started steroids, although that steroids may be related to the testosterone or sex hormones, but steroids are extensively used in our clinical practice. So somebody who is taking steroids, you must remember that steroids inhibit the formation of T3 and promote the formation of reverse T3. All right. Now, function of thyroid peroxidase. I told you it's very important. The first function is oxidation, and it converts it into I2 iodine, and then organification of iodine, which means addition of iodine into tyrosine, which made it monoiodotyrosine and diiodotyrosine. And the third function is the coupling of monoiodotyrosine and diiodotyrosine to form the T3 and T4. As you can see, DIT plus DIT is equal to T4 and DIT plus MIT is equal to T3. And again, we have PTU and methimazole, which inhibits this. We will study these thiazolidinediones. Basically, both of them are called as thiazolidinediones. So we will study them in pharmacology. Now, what is Wolff-Chaikoff effect? Now, one thing is for sure that iodine is required for formation of these thyroid hormones. So, what if a person is getting excessive iodine? The body will realize that there's a problem. There's a lot of iodine. So, let's do something to avoid formation of lot of thyroid hormones, since we don't want excess iodine to make excess amounts of maybe thyroid hormones. So, what happens is that body tries to inhibit the formation of thyroid hormones, and that inhibition may even lead to instead of preventing the increase, it may even decrease the thyroid hormones. So what Wolff-Chaikoff effect says, it is a protective autoregulation in which sudden exposure to excess iodine temporarily turns off thyroid peroxidase, and that may lead to decreased T3 and T4, because we had a fear that this excess iodine may raise the T3 and T4. So we completely turned off the thyroid peroxidase, and that led to an ultimate decrease in T4 and T3. So that's a very interesting point. Iodine is involved in the formation of thyroid hormone, but sudden exposure to excess iodine leads to decreased T3 and T4. Now you may get a clinical scenario in which there is a worker working near a nuclear maybe reactor, or there is radioactive iodine exposure. They simply tell you, and prophylactically we give potassium iodide to such patient. Now what happens when we give potassium iodide? Potassium iodide also competitively inhibits the absorption of radioactive iodine. What basically we are concerned about is that you can see there is intake of iodine. Now, if there is a radioactive iodine, so we have a fear that if thyroid intakes the radioactive iodine, that radioactive iodine will destroy thyroid gland because of the radiations. So we give the patient a lot of Ki or potassium iodide, so that the absorption of potassium iodide may competitively inhibit the absorption of radioactive iodine. So this is the first advantage of giving potassium iodide when there is exposure to radioactive iodine. But the second advantage is that excess potassium iodide also decreases the organification, and it decreases the overall absorption of iodine, because it decreases the overall formation of T3 and T4. And how do potassium iodide decrease the formation of T3 and T4? With the help of Wolff-Chaikoff effect, right? So this is the application of Wolff-Chaikoff effect, the useful application. Now, since we are done with all these complications, all these complex concepts which are very, very high yield, I'm telling you they are very high yield, especially the functions performed by thiodine peroxidase and the conversion of T4 into T3. You're going to get clinical scenarios in which you will be given that there's a person with the raised T4 and raised T3, so you will realize that there is increased formation of thyroid hormones. Or you may get a scenario in which there is maybe raised T3 with low T4, so you may understand that he is getting exogenous T3. Or you may get a scenario in which there is raised T4 but low T3, so you may understand that the conversion of T4 into T3 is inhibited by some kind of glucocorticoids or beta blockers, or propyl thiazide acid. So they are going to use this knowledge very extensively. All right. Now, what are the functions of thyroid hormones? Thyroid is a very energetic kind of hormone. It increases the basal metabolic rate, it increases the heart rate, it increases your sweating, it increases your temperature of your body, and even in hypothyroidism there are tremors. So it increases the muscular contractions, and it's a very active kind of a hormone. So let's have a look on the precise mechanism. So they call it as 7 B's. B. All right. So it helps in the brain maturation. It helps in the brain growth and beta adrenergic effect. Now this is very important. So thyroid hormone increases the beta receptors in the heart, and so since beta 1 receptors are increased, and we know that beta stimulation increases the cardiac output, the heart rate, and the stroke volume. So thyroid hormones are also involved in increasing cardiac output, heart rate, and stroke volume. And so in a scenario of hyperthyroidism, there is a patient with palpitations and increased blood pressure and these kind of symptoms. And as I have already mentioned, it increases the basal metabolic rate. And how is that so? Because sodium potassium ATPase activity is increased. Sodium potassium activity is increased. There is increased requirement of energy, and so thyroid hormone makes the basal metabolic rate increase. And what basically happens is that if a person has increased thyroid hormone, that will lead to a lean body because more energy is used. So a person is eating a lot of food, but he is unable to gain weight. Instead, maybe he is losing weight, and that means that the thyroid hormone is raised in him. I mean, raised thyroid hormone may be one of the conditions. There might be other conditions which can cause weight loss, but raised thyroid hormone is a very important condition. And so the thyroid hormone also increases the blood sugar because, of course, it's a very energetic hormone. It wants you to perform activities, and it is involved in the breakdown of lipids. I just mentioned you that it leads towards a lean body. Last but not the least, surfactant production in the babies. Now let's have a look on the regulation of thyroid hormone. Although we already have a brief idea because we have studied the hypothalamic and pituitary hormone, we are going to have a great repetition of all the information, even in physiology and then in pathology, so that it will become easy for you to memorize these points. Now there is thyroid releasing hormone released by the hypothalamus, which leads to increased stimulation of thyroid stimulating hormone by the pituitary gland, and that thyroid stimulating hormone causes hyperplasia of follicular cells. In fact, it increases the follicular cells of thyroid gland. And so in Graves' disease, there may be increased thyroid stimulating hormone, which leads to increased production of thyroid hormone. So Graves' disease is basically a disease of hyperthyroidism. Now, what basically happens is the negative feedback is mainly regulated by the T3. So T4 is converted into T3, and then this T3 goes all the way back to hypothalamus and informs the hypothalamus that come on, T3 is being produced, I am being produced. There is no need to release thyroid releasing hormone because T3 is already in excess. So there is formation of T3, and that T3 negative, but by a negative regulation, it goes back and it inhibits the TRH. So it also inhibits the TRH and decreases the sensitivity of TRH. I mean, in case it goes to the TRH and TRH refuses to decrease its quantity, so what T3 does is that it realizes that TRH has gone mad. So it goes to the pituitary and asks the pituitary that please, you do not respond to thyroid releasing hormone. It has gone mad, right? So it simply decreases the sensitivity to thyroid releasing hormone. I just made up this story to make it easy for you to understand. Now there's another thing called as the thyroxine binding globulin. Now, a point to understand is that inside blood, most of the T4 is in an attached form. It is attached with thyroxine binding globulin. So we can divide T4 into two. We can say the total T4 and the attached T4. Since total T4 is divided into the bound T4 and free T4. Sorry, I made a mistake in my statement. What I wanted to say is that we have two important parameters. One is the total T4 in our body, and the second parameter is the free T4 in our body, right? So in total, we have T4 in a bound form and in a free form. But in laboratory test, you may have values in which you get total T4 and then you get free T4. So what you realize is, for instance, there is a normal quantity of total T4, but there is increased free T4. This means that there is a deficiency of thyroxine binding globulin. That is why there is increased free T4. And in case where there is decreased T4, you will realize that maybe thyroxine binding globulin is increased. But now there is a very interesting role performed by the negative feedback. Now, what basically happens is there are some scenarios in which thyroxine binding globulin is increased, such as the estrogen increases it. So, in pregnancy or in use of oral contraceptives, the thyroxine binding globulin is increased. And similarly, some factors decreases thyroxine binding globulin, such as in nephrotic syndrome and in steroid use, they are decreased. So, a common man may understand that increased thyroxine binding globulin will decrease the free T4. But what will happen when there will be a decrease in free T4? There will be a decrease in T3 because free T4 is converted into T3. So when there is decreased T3, there will be decreased negative regulation. What will happen is that when there is decreased T3, the thyroid releasing hormone will be increased, thyroid stability hormone will be increased, and new production of T4 will be increased. So ultimately, increase in thyroxine binding globulin will have an increase in total T3 and T4, and that is because of the stimulation by TRH and TSH. So this was a point which can be tested in any kind of a scenario. This was all from thyroid hormone. Oh, another interesting information which I have mentioned right over here is that there is release of thyroglobulin along with the thyroid hormones. So when the thyroid gland releases thyroid hormones, it also releases thyroglobulin along with it. And this is very important to understand because the quantity of thyroglobulin in blood will give you a very good idea about the releases from thyroid hormone. So if you have raised T4, T3 in your blood, but low levels of thyroglobulin, this means that this T4 and T3 is not released from thyroid. Instead, the patient is taking exogenous thyroid hormones. And if there is a raised level of T4 along with raised level of thyroglobulin in the blood, this means that thyroid hormone is producing excessive thyroid hormones. Thank you very much. I hope you enjoyed the video.